Okay, now that we've gone through the anatomy and physiology of the heart, let's talk about the electrical activity within the heart, because at the end of the day, the heart is an electrical organ. Okay, so to talk about the electrical activity of the heart, we need to first discuss the myocytes. They're really unique for a handful of different reasons. They're listed out here, so let's dig a little bit deeper. Myocytes are actually a combination of skeletal and smooth muscle. The skeletal muscle gives it strength, and it also gives it the power it needs to move the blood where it needs to. It really can clamp down with the force necessary. But the other part, having the smooth muscle in there, also gives it the stamina it needs to beat over and over again, constantly, day after day, maintaining some tone at times as well. So that's what's important about the type of muscle it is. Another important part is that they're branched and interconnected. Normal skeletal muscle, like in your bicep, is each muscle cell is individually packaged, almost like a package of hot dogs if you really want to think about it. They're all side by side, they all move in one direction and one direction only. Now, smooth muscle is usually branched and it's interwoven, interconnected. It can stretch in 3 dimensions, almost like cloth can or fabric. So, myocytes are actually kind of both. Each cell travels in a general direction but is branched and interconnected to the next one. Um, it's coupled to its neighbors. And so to draw this out, it actually looks something like this. One is connected to another one, 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 etc. And so you get this interbranching. Heck, we'll connect one right there. You get this branching, this network that's laid out. And what that does is allows them to communicate with each other, because they also have this unique feature called the intercalated discs. And what that does is it allows everything to be shared between these cells, from the electrolytes and things within them, but more importantly, the electrical impulses, so that if one cell fires, that information or that electrical impulse here is going to be shared out in all directions in a cascade. And that's what's called cell to cell conduction. And that's a hallmark of myocytes and this type of muscle, and it's really important for the function of the heart overall. The next part, sorry, while I'm still on that, that interconnection, that cell-to-cell conduction, is what allows a impulse that starts in the SA node to travel throughout the entire atria. And then it's also why the entirety of the ventricles can contract, even though there's not a single nerve attached to any group of cells, which is really, really cool. Now, automaticity is the next part that makes these things so cool. And it's the idea that any myocyte throughout the entire heart has the capability of generating an impulse. And that's really, really cool, so that there are certain areas of the heart that specialize in generating impulses, and they're usually what's in control. But the fact that if those aren't working, other cells could take over if need be. It's also a drawback that any one of those cells could also decide to throw a temper tantrum and take over control of the heart. We'll talk more about that in a bit. Final portion is going to be conduction. And what this is basically that cell-to-cell portion of it means that each cell can conduct an electrical impulse from one cell to the next. And normally this is cool and it heads in one direction. So normally everything travels the way it should, from the SA node to the AV node and down through the rest. But this ability to conduct is actually a two-way street, and so you might actually wind up with retrograde, where the cell's actually conducting backwards. So we'll say happy for this, and we'll do that. And even more so about the retrograde is it can actually travel sideways if it needed to. It can travel in almost any direction. So combination of skeletal and smooth. They're branched and interconnected. They have automaticity, and they can conduct between one another. Those are the hallmarks of myocytes that make them so cool. So two things I want to say right off the bat. One, I absolutely love this diagram. It is fantastic. This is the true anatomical layout and musculature of the heart and the electrical conduction system. You know, anything from the muscle thickness on the left ventricle compared to the right atrium, all of this stuff is really accurate. So sit back, it's going to take a few minutes to get through this one. This is going to be a pretty involved slide. But we'll start out with the good old SA node. Now the SA node, the sinoatrial node, is responsible for initiation of all of the normal heartbeats. It's a collection of myocytes who have their own intrinsic rate, or their native rate, of about 60 to 100 beats per minute. And that's about where they sit. This makes it the fastest part of the heart in terms of that automaticity rate. And it's usually what's in command in a healthy heart. Now, the SA node is connected to internodal pathways, and that's these guys right here. And these internodal pathways act as high-speed conductors. They carry the electrical impulse across the right atrium and the left atrium as rapidly as possible. And there's a lot of cell-to-cell conduction that helps keep things moving along in a organized fashion. So you get that rippling effect that not only I'd compare it to like when a boat's going through the water, that it creates these waves and ripples beyond it, so that not only are they cascading out from the sinus node, but then they're also cascading out from each of these internodal pathways nearly simultaneously, so that you have almost the entirety of that right atrium contracting at almost the same time. Just starts from one end and moves towards the other. The difference between a internodal pathway and a cell-to-cell conduction is probably the difference between posting something up on Facebook as opposed to, you know, texting someone individually and asking them to text the next person, etc., etc. Next up is going to be our AV node, and so that's your atrioventricular node. It's a group of myocytes responsible for collecting the impulses from the atria. They wait a few milliseconds and then conduct it to the ventricles. They act as a gatekeeper, essentially. Naturally, this is actually the only point where electrical conduction can occur between the atria and the ventricles. Because those valves that we talked about earlier are made out of cartilage, they actually insulate the entire top half of the heart from the bottom half of the heart. And so what that does is creates a situation where this is the only place electricity can travel through, which is really good, because with all that cell-to-cell conduction, it could get pretty messy pretty quick. Now the AV node, what makes it unique is it has its own intrinsic rate as well, its own natural rate, and that is between 40 to 60 beats per minute. So it makes it slower than the sinus node, but fast enough that if the SA node were to fail, the AV node could take over and still keep a reasonable heart rate going for whoever the patient may be. Next up in line is going to be your bundle of His, and that's this section through here. And the bundle of His is actually a collection of Purkinje fibers, and it's the root of the bundle branch. So we'll unpack that a little bit. So Purkinje fibers they're like fiber optic cables. They function to carry the electrical signal from its origin at the AV node to wherever the fiber ends in a really rapid fashion. It's essentially the same idea as those internodal pathways. So that a single Purkinje fiber starts up here and will travel the length all the way down to the very tip over here. And then there's another one next to it that goes here, etc., etc. It helps carry the information faster, which is what you need because that left and right ventricle are so large that to rely on cell-to-cell conduction would take too long and would likely be a lot more disorganized if we did that. So the bundle branches. You have a right bundle branch and a left bundle branch. So I'll draw this arrow over here for your right bundle branch. And so it travels next to the endocardium. So it's just underneath that cartilage layer that is lining the inside of the heart. And what that does is it sends its spark out next to the inside of the heart so that the muscles of the heart actually start contracting from the inside to the out, which is cool because one, that'll help push the blood out because you don't want to trap blood in there. And two, it helps make sure it's contracting in a way that helps maximize the squeeze. Your left bundle branch, which is this portion here, goes all the way down to the tip of the apex and then back up the side. Because the left ventricle is so much larger than the right ventricle, it actually divvies up into two different sections here, which is left posterior fascicle and the left anterior fascicle. Sorry, I butchered that a little bit there. So the left bundle branch actually has two sub-branches. Regardless, they're high-speed conduction pathways that just help move the electricity through the heart as quickly and organized as possible. Last thing I want to say about this is the layout of things and the fact that your bundle branches, I'm going to draw this over here because there's a little more space, are laid out in a way that they actually go down and wrap up the sides. And the reason why we depict it this way is it's just easier. But that's really cool because it means that the center of the heart, that IV septum, is what's going to contract first. And then the bottom parts of the heart contract next. And then the sides contract, which is a really clever plan because if you're going to contract, you want to have something solid to push against. So if your IV septum has contracted first, and then your ventricle starts contracting at the bottom, and so on, it's got something hard to push against, and that's what's going to allow it to really squeeze the blood out. It's not much different than squeezing your toothpaste from the bottom rather than the top of the tube. You get the most successful ejection of blood this way. So while we're on the topic of heart rate and how the heart behaves in that regard, let's talk about what controls your heart rates. So we use something called the pacemaker rule, and it's the idea that the pacemaker site with the fastest rate will generally control the heart. And so your inherent or native rates should be your default settings. So we want the SA node to be in charge most of the time, well, pretty much all of the time. However, a couple different things can happen. If for some reason that sinus node slows down, it's going too slow for whatever reason, or stops altogether, our body does a couple other things as escape mechanisms. And so an escape mechanism is when the normal pacemaker fails, you'll have something like the AV node kick in and try and take over. And worst case scenario, you might even have your ventricles take over and keep the heart rate going, worst case scenario. On the other side, what can happen is instead of having a sinus node that had slowed down too much, instead you can find a site with irritability. And this is where that automaticity of every myocyte comes in, is that any cell along the conduction pathway can speed up. And if it speeds up enough, it can actually take over as primary pacemaker. And I'll talk about that a little bit more in a second. So your inherent rates. Each area, I've mentioned this a little bit already, but I just figured devoting a single slide to it would be wise. Your sinus node is going to be your fastest at 60 to 100 beats per minute, and it's normally in command. Your AV node, AVN, is your second fastest at 40 to 60 beats a minute, and you can see how those ranges don't overlap, and it usually will take over if the sinus node fails. And then lastly, should both of those no longer be in command, you're left with your ventricle, which has the slowest. And when I say ventricles, I mean the cells in general. This is about the rates that they run. And they will take over. That is, of course, the least desired situation that you want to run into. Why? Why does this exist? Why is this something that we have to understand? Well, it's for fail-safe reasons. The body will do just about anything it can to keep itself alive as long as possible, whether it realizes it or not. In fact, there's many cases and examples of people who were born without a functioning sinus node, and they never knew it. They just always had a slow heart rate most of their life, and then they're in their 40s and they're getting a workup for a knee surgery or something like that, and they find out that they've been in a rhythm where the AV node's been in charge their entire life and not even realized it. So just one of those cool, interesting things that it works, because if you survive to adulthood, well, then that means you can procreate, have kids, do all that jazz. So your biologic imperative has been met. Just another walkthrough on irritability, because this really is the foundation of basic arrhythmia and advanced arrhythmia and all of that jazz, is the fact that arrhythmias occur because a group of cells, and it can be pretty much any cell, has become irritable and sped up to the point where it overrides the natural pacemaking cells of the heart. And that's what these are. So your AFibs, your A-flutters, even your V-tach, all of those are irritable cells who've taken over control of the heart to a certain extent. Of course, we always have to ask the question, what's causing it? Can we reverse it? Things of that nature. Well, anoxia is a great one. Even if it's just a drop in O2 sats, below 85 or 80, or it could be something as significant as an MI, where you've completely blocked blood flow to the heart. Another good one, lots of chemicals and drugs can do that, but of course, digoxin's one of the most common ones. Electrolytes can cause it. If your potassium numbers get out of whack, that can totally cause troubles in this regard. And mechanical traumas is another great one, where you've got maybe a motor vehicle crash, or even a baseball to the chest is another great one. A line drive can cause these kinds of things to happen. It's pretty nuts. But that's, at the end of the day, regardless of the cause, we always seek to identify and correct the problem, get our patient back to a normal rhythm as quickly as we can, because that's what we want. And if it's not possible to correct the arrhythmia, we always do our best and get it as good as we can. Please identify the following structures. You have your list on the left: SA node, AV node, bundle of His, right bundle branch, left bundle branches, and Purkinje fibers. And of course our letters are on the right side, so let's just go through these. Our sinus node, well, that's going to be E, the little green dot there, of course. So that's your sinus node. Your AV node, well, that's going to be A, correct? It's right there in the center. As for B, well, B actually works out to be your bundle of His. Your C, is that the right or left bundle branch? Well, it's going to be your right bundle branch. So that's C. Left bundle branch then is D, and your Purkinje fibers are G, way down at the bottom. Cell-to-cell conduction of an impulse between myocytes and throughout the entire heart is possible thanks to which of the following? Is it because the human body is made of 70% water, the intercalated discs, hard work and determination, or myocytes are branched and interconnected? Well, really, you can just look at the slide and tell that these are the two that are actually listed. While hard work and determination is important, it's not really what allows cell-to-cell conduction. And the human body being made of 70% water is convenient and part of the equation, but not the reason why the impulse can be conducted. It really comes back to the intercalated discs and the myocytes being branched and interconnected. Please list the inherent rates of the following pacemaker sites within the cardiac conduction system. And there's a very specific slide that lists all these out if you want to go back and refer to it. But we'll just start. Which of these sinus node ones are correct? Well, the sinus node of 40 to 60, that's absolutely not correct. So we'll take B off the list. Sinus node between 80 and 110, that's also incorrect. So we'll take that off the list. So now that brings us down to A and D. Which of these is most accurate? Well, the AV junction, does it go 40 to 60 or 20 to 60? Well, of course it's not D, so we can take that one off, which really just leaves us with A. And that is correct. Your sinus node runs from 60 to 100, your AV junction is 40 to 60, and your ventricles are 20 to 40. If you look at these other ones, you'll see that that one's incorrect and that one's incorrect as well. Which cells along the conduction pathway are capable of taking control as the pacemaker of the heart? Well, which one of these already are involved in the conduction pathway, I think is a better way to look at this question. You've got your SA node, which definitely is. You've got your internodal pathways, which definitely are. Your AV node is part of that. Your bundle branches are part of that. Your valve leaflets, I've not even listed them once, so you know that that's definitely not part of this list. But individual myocardial cells are, because each cell has the ability to do automaticity and start off on their own. So valve leaflets is the only thing on this list that is not capable of taking control as a pacemaker of the heart. Irritability of cardiac cells and potentially life-threatening arrhythmias may be caused by which of the following? As we go through the list, and I've talked about it multiple times, that ischemia, anoxia, that irritates any set of cells, so particularly of concern. Medications will definitely cause this. Methamphetamine's a really good one. Adrenaline, the natural system that the heart uses to speed itself up, that the body uses. Adrenaline increases irritability. Mechanical trauma, bruising of the heart, a steering wheel, things of that nature could even cause those cells to become irritable. Cardiomyopathy is definitely one. You stretch out that heart and you cause it to be misshapen. That creates some irritability. And your electrolytes within normal limits. If everything's normal, then it's not a problem. So electrolytes is the only thing on that list that is not potentially going to cause irritability of cardiac cells.